Hi everyone, this is 𝗥𝗶𝗳𝗲𝗵, and today we have a new webinar, and the topic today is going to be about different scenarios using rising system by Fanta. It's a rotary endodontic system. So I have BDS from University of Baghdad, Iraq. I have LDS from the Royal College of Surgeons of England. I have MSc in Endodontics from King's College, London. And also I'm a gold member in Style Italiano Endodontics, and I'm certified Invisalign provider. So Rising, it's a rotary system by Fanta. It has unique design, unique specifications we will go through, and how we're gonna utilize these things in our daily practice with different scenarios that we may face. So Rising system, it has a special design, and that's it. They have, or there is different, we have different taperness or variable taperness across the file. We have variable cross section. I mean, the cross section is different in each part of the file. And also there is different niti for each file of the system. So not the whole system comes with one niti. Each file of the system depends on its usage, has different niti according to that usage. So this is rising system. This is how it comes. The kit consists of 5 files. First file is going to be this one, which is open file, and then we have this one, gold file, blue file, gold file, and silver file. So we'll go through each one of these files. So yes, these are the files of rising system. I'm gonna fast forward. So if you see, even the open file, it's very flexible. Shape memory, good shape memory, good shape control. They are all heat-treated files. Same for the other files, it's the same. Very flexible files. This is the most important file for me, actually, size 25, if you can see. And we'll go through each one of these files. Now, these are the files. We have the first one, which is orifice opener or open file. It's RR, the size is 17, taper 10. And we have, just like, let's say, a glide path or path file, it's R1, size 13, taper 3. Very nice. Then we have R2, which is 25, taper 4. Then we have R3, 30, taper 4. And surprisingly, the last file, which is green, which should be, or you may assume it's 35, but no, it's 28, taper 5. And we will go through that. How we're going to use the rising system. So this is the first scenario. It's just like everyday case. We have pulpitis, upper second premolar, symptomatic reversible pulpitis. So after isolation with rubber dam, now negotiating the orifice, and then we will use the R1 for coronal preflaring, which is 17, taper 10, size 17, taper 10. The whole kit is minimal invasive because they have decreased taper or diameter at the coronal part. So it's very minimal invasive file. If you see now, which is the RR open file, which should be the widest one coronally, after preparation, not that much. We didn't take that much. So preserving precervical dentine. Now negotiating the canal, then taking the working length with K file 10. After working length determination, now we're going to use R1, which is 13, taper 3. It goes very smoothly inside the canal. This is the pulp. These are the pulpal tissue. Now, R2, most important file, in my opinion, size 25 taper 4, even though we have high jump, let's say from 13 to 25, but it goes smoothly inside the canal. Thanks to the specific design of the file. Then 13 taper 4, which I ended this case. So after preparation up to size 30, you see it was a really minimal invasive because there was we preserve vital dentin, and then I use 28 taper 5, and I will explain why. What's the usage of this 25? Because we already prepared 30. Why we have used size 28? So see, minimal invasive, preserving pericervical dentin, and this is after obturation. This is the final situation. Another scenario, we have a patient presented with upper 4. If you can see upper left 4, there is a crown, and also there is a bridge from upper 5 to upper 7. We started with upper 4. Why? Because it was painful, it was necrotic. Patient had pain, continuous pain and tenderness to percussion. She had pain when eating and a little bit swelling, so the tooth was necrotic. So after removing or dismantling the crown, we started. In treating necrotic cases, you should be careful. I really consider necrotic teeth as a ticking bomb. Why? Because you should work carefully, because any mistake can lead to a flare-up, post-operative flare-up. So the thing is, we need to work in crown down technique. So carefully, coronal part, then middle part, then the apical part, because I don't need to push any debris. I don't need to push any infection to the periapical area, and then we have flare-up. So very carefully, third by third, never put K file or any hand file immediate to the full working depth. No. Work third by third, disinfect third by third. So we started with the coronal third. This is the RR17, size 17 taper 10 for only few millimeters. 4 or 5 millimeters, that's it. No need to go much. Okay, see all of these infected dentin, if you push them, it easily can make flare up. Okay, especially for upper premolars. You know why? Because in majority of cases, the pieces of upper premolars are near the cortical plate or sometimes outside. So in many situations, the apex or the apical foramen of premolars are outside the bone. So it's easily access to soft tissue. So it's very easy to get swelling. So and you can notice this if you take CBCTs for your cases, and you'll see what I'm talking about. So upper premolars are very easy to cause flare up. So if you see in each stage, because it's necrotic, I'm doing disinfection with ultrasonic. Then I didn't go for full working length. Okay. Middle third. Now I check why, because I disinfected. Yeah, we're good to go now. Because in coronal pre-flaring, you will remove the majority or the bulk of infected tissue, or even in vital cases, you remove the pulp tissue. So after disinfection, good disinfection, with the ultrasonic, now I can proceed carefully with K file 10 to full working length. Then I'm going to use size 13 taper 3. Okay. And if you see, even it's necrotic, but I don't see in the X-ray, I don't see any shadows of the canals. And it's a long tooth. So it means they are narrow. Okay. Even if it's necrotic, see, It's not, there is a little bit resistance, but the file goes smoothly inside the canal to full working length. Now the other canal, the buccal canal, the tooth is long, narrow canals, a little bit calcified, let's say, but it goes smoothly thanks to the variable taperness, variable cross section of the file, and the nice night tie for each file, designed for each file. Good irrigation. Also activation. Each stage I do activation for necrotic teeth. See how much debris we are getting? These debris may easily go, it can be pushed outside the tooth, outside the root canal system. Let's fast forward. See, we're still having debris. Now I'm going to use R2, which is 25 taper 4. You may think it's not going to be easy because the canals are narrow and we are jumping from size 13 to 25, but you see it goes smoothly to full working length. And thanks to the design, if you see, we have good debris removal and coronal direction because of the variable taperness, because of the variable cross section of the file. Again, disinfection, irrigation, ultrasonic activation, and then we finish the case. We finished the case, and also then I did retreatment for the upper 5 and root canal for 7, and this is the final situation. I used all rising system. So this is very nice X-rays because um, you uh, you don't see such X-rays more often. If you see that the file system has preserved the anatomy of the root canal system. Look at the curves of all the teeth. So it was following the anatomy, minimal invasive, and if you can see also the taperness from the apex to the crown, very nice taperness and very minimal invasive. Now we have another case. It was upper 6. It was a symptomatic irreversible pulpitis hot tooth. If you can see not only the canals, but we don't see the pulp chamber, only very small shadowing. So yeah, the tooth was very calcified. After access opening, see hot tooth, then we have the pulp stones. This is the anatomy, or this is the pulp map of upper first molar. Okay, it's wider in the buccal, then in the palatal it comes like a triangle or a pyramid. But it was the opposite. It was just a line. So first I could find MB1, then distobucal, then I could find palatal and MB2. And this is the final situation. This has been treated by rising system. Even MP2 we could find, negotiate, and then prepare with rising system. So this is what I used to use with the rising because I didn't get the idea of what's the point of we are having size 28 after size 30. So let's imagine you prepare the canal with size 30 taper 4. So this is the canal after using size 30 taper 4. Then at this case, so the D0 of the prepared canal should be 30, okay? And the D1, because it's taper 4, it's going to be increased by 4, which is going to be 34. So the D2 would be 38, and D3 will be 42. So this what should be ideally the prepared canal after size 30 taper 4. So what's the point? I'm using 28, which is less. So consider it just like mechanical recapitulation to enhance irrigation. How is that? So this is the prepared canal after size 30, taper 4. When I use 28, taper 5, so at the D0, it will not touch the walls. Why? Because it's 28. The canal already prepared to size 30. So it's not gonna touch the walls at D0, at the apex, because it's 28. Then at D1, because it's this 28 taper 5 will increase 5, it's going to be 33, which is also less than the prepared canal because it's 34 at D1. Okay, then here it will touch the canal. It's the same at D2 because it was 38 with 30 taper 4, and now D2 of 28 taper 5 is also 38. So now start touching, it's not preparing anything from the canal. But here at D3, it will take a little bit from the canal, a little bit. So just like refinement of the canal, refinement of the apical portion to remove any debris, just like a recapitulation, remove any irregularities. So at D3, instead of 42, because it was prepared with 30 taper 4, it will be 43. This is the only change. So it's not going to change anything from your um, preparation size or also obturation. And then it goes back, it will not touch. So just like recapitulation. This is nice case. It's lower, first molar. It was very long, and also very calcified, narrow and calcified. Okay. So calcified pulp chamber, but I could identify the pulp map. Okay, I use RR, coronal pre-flaring now. If you can see, 17 taper 10. Very calcified pulp chamber. Even the K file 10 is not easy going. Even C file 10 not easy going. But once you locate the canal carefully, it needs a little bit experience, but it was okay. Then negotiating the canal with K file 10 to full working length, measuring the working length of the canal. Then I use R1, 13 taper 3. In these cases, it will be a little bit difficult. Why? Because calcified long molar. But if you can see, even though it went smoothly inside the canal, very calcified. Okay. And then the distals now. And then we have the R2, which is 25 taper 4. Also, it went smoothly with these long calcified canals. The distals. And then we are using the R3, which is size 30 taper 3, taper 4, sorry. Also went smoothly inside the canal. And then I have to do refinement for the pulp chamber because I need to remove all calcified pulpal tissue, pulp stones, because they may be infected. I need to remove any isthmuses. So this was refinement, and this is the final situation. This is the final situation. So to summarize, rising, I'll be honest with you guys, not because I use Fanta a lot, and but the thing is, because Fanta they have a lot of file system, but as a rotary, they started first with the AF rotary file, which was magnificent at that time. I consider this system rising as an update, let's say, of AF rotary. It can be used for all level of dentists, from fresh graduate to more experienced, complex cases. Uh, Fresh graduate, because these files are easy to use, they are very simple, very flexible. We mentioned safety and not easy to get fractured. It can go smoothly within the curves of the canals. It preserves the anatomy of the canal, minimal invasive system, good coronal removal of debris in coronal direction, a variable cross section, variable taperness. It's very nice system, and also we can use it to more complicated cases, just like we saw about curved canals and very calcified canals. I'm using this in daily basis, to be honest. Although my favorite file is F1, but this is very nice system. Um, Please, if you have any question, I'm more than happy to answer. And until next time, take care.